stability. Ok, on va envoyer la communication qu'elle nous a envoyée et puis elle peut intervenir. Allô, allô, les fois poser une question, dans 30 minutes, contacter allez voir, un téléphone. Allez voir, présenter. Ok, les nombres de secondes. Nous allons écouter le... Les femmes feux? Le son, s'il vous plaît.
That we are based here in Mexico. As you all know, mycetoma is a worldwide disease. It affects mostly in intertropical areas. That is also known as the mycetoma belt. There are very well-known endemic areas as India, Sudan, Brazil, and also Venezuela and Mexico. Actinomycetoma is more frequent in Latin America. It is mainly caused by Nocardia brasiliensis and Streptomyces somaliensis. And in Eumycetoma, Africa, Asia, and India are mostly with cases of Madurella mycetomatis. Mycetoma has been recognized as an entity since 2016, which made a big relevance regarding the differences between identifying a disease that can be with a very high morbidity. As you know, mycetoma is an inflammatory chronic syndrome. It affects mostly skin, hypodermis, bones, and sometimes even the bowels. And it's very characteristic, the volume increase with the presence of fistula, with the presence of also seromatic purulent exudate, in which we will find the presence of this parasitic form that is also known as grains. Well, patients in our environment, it's very common that they carry wood bales on their backs, so that's why in the scapular area it's not rare to see this kind of cutaneous diseases because of it, minor trauma. The mycetomas, it's very important to identify the host immune response, which is in most of the cases deficient, and that will cause an accumulation of neutrophils, and that there will be filaments in the tissue with the formation of these grains, the parasitic form, that will be discarded among mucoid or purulent exudate. These patients will also have very evident and very palpable fibrosis. There will be vascular neoformation, which that causes also that most of the lesions can be very friable, and that can cause among the seromatic purulent, it can be presence of blood. And of course, depending on the evolution of the patients and the time that it has been affected, they can have bone involvement. Mycetomas have multiple study areas for it, including therapeutics, epidemiology, diagnostic, and it is a disease that has to be approached in a multidisciplinary way. It affects mostly lower limbs, mostly in abdomen. Also, we see it a lot in abdomen, perianal area, in the dorsum, as I mentioned before. And of course, we have seen some other cases with cervical involvement. It does need a traumatic inoculation with organic material in most of the cases. In our environment, Huizaches, which is a form of a plant, can cause, we can see some of the thorns of this kind of Huizache, and it's because patients have inappropriate footwear that they get minor trauma. They usually wear sandals and they get inoculation, traumatic inoculation. But we also have seen some cases that are caused because of unusual vectors like wild animal bites like iguanas or some other kind of animals. And those cause minor skin injuries, and of course that causes that the mycetoma can be developed. This is a disease that has a very high morbidity, as I mentioned. Mycetoma is a neglected disease. It is neglected in endemic areas, and it can be neglected by patients, at the communities, by medical authorities, and by health authorities. That's something that we see in our environment. And unfortunately, I think no matter where, poverty is a common denominator, because it's a disease that, because of its late presentation, and because that it does not have symptoms, usually they are none or very mild, patients tend to neglect it in time, and that can cause that these patients will have serious consequences in a long-term basis. In our country, we have most of our cases that are caused by Nocardia brasiliensis. Actinomycetomas comprehend about 98% of the cases, and only 2% are caused by eumycetomas. In our state, which is called Guerrero, it changes the statistic up to not from 2 to 9% or even more. As I mentioned, farmers are the most frequently affected group, and because of this, we such as thorns, because they also use it in the households, for fences, or they use it for wood, for cooking. So it can be very frequent that they also use, and they get these minor injuries. We have also mycetomas, forms of encrypted or apis. And but of course, we always have to think about these other presentations. This is a publication that part of the group of Dr. Chavez Estrada and Bonifaz published in the International Journal of Dermatology about perianal actinomycetoma, which is not rare in our environment because people use any kind of organic material to clean themselves whenever they are working at the fields. And we have had some other cases of cervical and cervical dorsal mycetomas, which is one of our interests, especially because these patients get severe morbidity, or even they can die from it because it can cause quadriplegia. And if these patients do not get treated or diagnosis in early basis, they will get very complicated, as you can see in this reconstruction of a CAT scan with a fusion of vertebral bones. And of course, the direct examination and the culture. And this patient, of course, also had some other comorbidities. And this was the patient that had the fusion of the vertebrae. She was already quadriplegic when she arrived to consultation. Mycetoma in our country, this is my country, Mexico, and this is the state of Guerrero. And we are based in Acapulco, which is in the southwest part of the country. And this, in our state, we have it's divided by several regions, and most of our cases are from the small coast of, which is called Costa Chica, small coast, and also from Tierra Caliente. These areas have very specific environmental characteristics, and that's why it has a very high endemicity of eumycetoma. It is the small coast and big coast is divided by Acapulco, which is the city where we are based. And we have a very high index of Mexican mestizos and Afro-mestizan mestizos in our country, that also we are studying if there is a relationship between the genetic background. Community dermatology program in Mexico is one of our programs that we are very focused on studying mycetomas. We have reported 115 cases, and they are mostly men, and most of them, almost the big majority of up to 45% are from the small coast of the state. From these, up to 80% are caused by actinomycetoma, identified as nocardia, either SP species or brasiliensis, and 19.2 were from eumycetoma. We identified most of cases were from Madurella species or Madurella mycetomatis. And we published it at the transaction royal social tropical medical hygiene. Actinomycetoma, if it's not treated early and appropriately, it can have very severe and deep involvement. We are mostly focused on preventing the bone structures not to be affected, as it can become a very disabling disease, as we can see in this image. This was a patient with a very inflammatory diseases, and it has lesions that affected a lot of the tissue. And of course, it developed scarring that limited the movement of the arm after the disease was cured. And there is still the need of effective management for actinomycetomas and for eumycetomas, of course. From eumycetomas, we know that the male-female ratio is from 3 to 1. Mostly are people between the 30 and 50 years old. Field workers, and 1.8% are caused by dematiaceous grains. Only 0.2 are caused by the white grains, and these are the species that we have identified most frequently. This is one of our very last cases of white grain mycetomas. These are very, very rare in our media. We don't see it that often, but the size of these white grains are from 500 micra to 2 millimeters. They're usually grains that look fragmented or with a very regular form. They are not as hard as you would think. And the colonies will be, it can have an aspect of white, brown, or even a little bit pink sometimes, and can follow with a vellus aspect, like a little bit hairy. And this is the other case that we have a white grain mycetoma, which is a very particular case that was identified as a Phomopsis longicola, which is a soybean fungus, and was confirmed by PCR, which was a very rare case. We have also seen some eumycetomas of black grains, and this was treated in the institution. We can see like the lesion that was not very big, but the grains, it has a very nice histopathology. And when we made the treatment, we had it treated surgically, and we can see how it was a pseudo-encapsulated lesion with a very high presence and a very multiple black grains in the middle of these small clusters. And that was a case that we published also in the International Journal of Dermatology. The cryptic eumycetomas, they have volume increase, they have a firm texture. They are mostly in most of these cases, that's why we call them cryptic, because they have minimal or absent fistula. In these patients, it's recommended to perform a deep biopsy from the soft or that a little bit fluctuant areas. And whenever we can get these grains, we always suggest the direct examination from this, as most of the grains can be microscopic. The differential diagnosis can always be a challenge, as they are frequently mistaken with osteomyelitis. That's why it's very important to have a X-ray and CAT scan, and whenever also available, ultrasound. It can also, so we can find these grains, or we can find suggestive information that can allow our diagnosis to be performed. It is very important to create awareness regarding the mycetomas and all these NTDs at these communities. That's why we, as a community dermatology group, we give basic dermatology to the last year medical students and that work at the communities. And that's why we always work in these areas for giving people the knowledge about how to identify this kind of disease. We also try to provide the information at the communities with people that can find with posters and fish, and so they can see how the disease looks, and whenever they identify themselves, because patients, they do want to know what they have, and they want to learn a little bit more about these diseases. This is part of the activities that we do sometimes, and we have always counted with the support of medical students, residents, social workers, and of course with the very dearest friends in like Professor Hay and Dr. Claire Fuller, among many others that have always been amazing with us, and we really appreciate their help always. Because what we want is our patients to not to wait until they have a very severe disease or they have very high morbidity, because that causes them a lot of stigma. We very care about educating our patients, because it is also important, the prevention, the mouth-to-mouth information, but adequate information. We want to promote the medical care because in that way our patients will be less frightened to receive the treatments, and it also gives them the sense of care. Let's remember that education is always an investment, and we want the patients that can be diagnosed and treated because at the end, myxotomas don't have to be a very complicated approach. Whenever you can make a direct examination, it's perfect, otherwise, or the culture. But if there are innovative, there's always the possibility for referral to third attention level centers. And we want our patients not to wait until there is a severe morbidity, because there can be some pulmonary diseases, or there can be deep involvement of these lesions. One of the problems that we see in our environment is that patients don't want to attend to consultation because they are very ashamed, especially whenever they have it in areas where they don't want to be seen as like perianal lesions, but they only wait until it's more extended in some other areas. We want our patients not to have cervical or spine involvement, of course, and also the dorsal myxotomas, and whenever there is a abdominal affection that they don't have consequences affecting internal organs. We have made actualizations of the epidemiology of myxotomas. We have shared information. We collaborate with some other groups because we think that it's part of the very important to continue the publications of whatever information that is always available, because this is a task that has to be worldwide, and it has to be with a lot of acknowledgement about it, with a lot of consciousness regarding the relevance of this disease. Our challenges is that in order to give solutions for the NTDs, we want to reduce the stress and stigma. We want to improve the quality of life, especially avoiding iatrogenic treatments, because they are unfortunately very common. We want to improve the skin health through education, awareness, and advocacy for our patients. The treatments are always a challenge because most of our patients are already with a delayed diagnosis. The poverty is very frequent. Our patients lack the resources, the knowledge, and also there is a very strong problem with the available treatments, and even more with the pandemic. Unfortunately, diagnostic tools, they are not always available in endemic areas. And the current treatment for myxotoma nowadays is still suboptimal. We have low cure rates, we have frequent recurrence, often leading to amputation in advanced disease. And that will only cause more fear, and that patients reject treatments and take those extreme measures from saying like, I don't want to lose my leg, and they prefer to die sometimes and have some other complications. And we have a lot of diabetes in our country, which it can complicate a lot myxotomas. Myxotoma is usually painless and it's slowly progressive, which is also not very helpful because that makes the patients neglected for a longer time. And they have deficient medical records in endemic areas, and there is not always this statistical information. That's why we are trying to make more awareness in our health groups. Our actual limitations is that a lot of patients also disrupt the treatment. There are not enough resources to continue treatment sometimes, either because of economical issues or because of available treatments. And also because they have a lot of fear. They don't like that they need to be in treatment for a long-term basis. And that's very important because these patients, at the end, they have very low income, and they will not be able, sometimes there is not always social medical assistance, that they will not always have it available. So the health resources are limited, as well as properly trained physicians that are available at the communities. And the patients are frequently discouraged from seeking medical attention, even nowadays. From the treatments, actinomyxotoma, we can treat it with streptomycin 1 gram every third day with trimethoprim sulfamethoxazole. And one of the treatments that we used a lot was with the combination with diaminodiphenyl sulfone, with a very nice results, but we have the problem that it's not longer available in our country. But there are some other options, either a combination with a cycle of trimethoprim, with ciprofloxacin, or but let's remember the average treatment duration is over a year. It's 14.52 months, so it's a long-term basis treatment. And for eumycetoma, surgery is only suggested in specific cases, and it always has to be treated previously with a systemic treatment for 3 to 6 months. Itraconazole, fluconazole, resorphobin, voriconazole, pulsaconazole, and amphotericin, they are always good options, but unfortunately they are not always available, or they are not affordable for the patients that work at the fields. So what we do is to approach and try to get as many of the treatment, or at least the most affordable ones, for our patients to be treated in a long-term basis and to reduce the drop-off of the treatment. In actinomycetoma, well, the problem is that dapsone is no longer available. Amoxicillin clavulinate can be used in pregnant women. Ipilimumab with amikacin, that was also published by Dr. Oliveria Welch. The problem is that they have to be hospitalized, and it's very expensive. All the treatments are not always available. And at the end, why mycetoma is jeopardized? Because it's misdiagnosed, frequently confused with osteomyelitis, and actinomycetomas are treated not rarely with antifungals or topical antibiotics by GPs. And like this patient that he was given a lot of antibiotics and or with antifungals, but it was an actinomycetoma, and the doctor, the general physician, did surgery every 2 months on every one of the fistulas, instead of giving an appropriate approach and an appropriate diagnosis. And let's remember, these patients do not have the economical resources for receiving the proper treatments. I would like to conclude that, distant communities, they lack this specialized attention. The isolation, poverty, and ignorance, well, at the end, they are the main contributors for disease conditions, for these serious conditions. Medical attention and treatments are very difficult to get since most of the times. And our group, we focus on giving and to dedicate this, trying to solve these problems from a dermatological point of view, which is our main goal. And I would really like to thank you all for your attention, and merci beaucoup.
Guadalupe Estrada, merci. Elle va intervenir pendant les questions après l'intervention du professeur David Dennings. David Dennings est le fondateur et président du Global Action for Fungus Infection, ce qui va terminer notre session de ce matin. Et pour les questions, donc je vous demande de préparer.
My name is very sorry to not be with you today in person in Madagascar, and also because of time change, I've had to record this talk instead of delivering it personally, and I apologize for that too. I'm speaking as the Chief Executive of GAFI, the Global Action for Fungal Infections, which we set up in 2013. Our vision is a world free from death and suffering caused by fungal disease. Today I'm going to focus on skin and skin diseases and NTDs in particular. But first, a brief summary. We think that on any one day there are about 13 million people at risk of a fungal infection, and probably about 2 million deaths. This means that fungal disease is probably the fifth biggest cause of death. However, many of the patients also have significant other underlying diseases, such as leukemia or COVID-19, transplantation, intensive care, HIV, etc. Based on limited data, we believe that about just under 50% of HIV deaths are due to fungal disease, particularly cryptococcal meningitis, histoplasmosis, and pneumocystis pneumonia. But also, fungal infections complicate TB, cancer, leukemia, COPD, and intensive care. And of course, we have a very large number of people with fungal skin infections, most of which are not dangerous in terms of survival, but they are debilitating and affect probably about 1 billion people. So if we were able to deliver current diagnostic tests and current antifungal therapies to everybody across the world, we think that about 1.3 million deaths could be averted. Unfortunately, the diagnostic tests are not perfect, the treatments are not perfect, and some people have very severe underlying disease and cannot be salvaged even with antifungal therapy. So that's why we don't think all the lives could be saved, but it's certainly a large number. So let me just go through this as a problem statement. I've provided the words in French to make it easier for some of you. So we believe that there's about 200 people who die of a fungal infection every hour, and about 2 million across the world. Most fungal infections are not transmissible, and they follow complications of other diseases, as I've said, such as TB, asthma, COPD, and these are airborne infections, the ones that affect the lungs. There are many patients with immune defects, such as HIV, cancer, intensive care, and these infections are generally transmitted through the intestine, candidiasis in particular, and or acquired in the hospital, such as aspergillosis. And then other infections are related to injury of the eye or the skin, and particularly with contaminated materials such as those working in agriculture. We have, in terms of a voice of these infections, the population of patients are very fragmented. There are small numbers of fungal infections in amongst a large number of patients with other problems. And we have very limited patient engagement across the world. It's really limited to aspergillosis. So we don't have a strong lobby group or voice from the patients about these infections. What we do have is some very good rapid diagnostic tests, the antigen antibody tests, which have helped, but there's probably access across the world is less than 25%. But we do know that early and rapid detection is very important. We also know that microscopy and culture are not very sensitive, with false negative rates over 50%. We have had quite reasonable antifungal therapies available for at least 50 years in some cases, or about 35 or 40 years in terms of the azoles, but probably only about 60% of the world's population have access to these. And we also have a problem, as you know, of a lack of clinical skills and laboratory skills in these areas. Also in radiology, there aren't enough radiologists, and there isn't enough access to radiology systems either. So I want to take you through one system that we've been supporting in Guatemala. This is focused on HIV patients, and what we were able to show is a reduction in mortality related to diagnosis. And we did this through what we've called a diagnostic laboratory hub, which is a single laboratory, but related to multiple different units looking after patients with HIV. And what we found is that using a combination of near-patient testing and reinforcing, automating and centralizing other diagnostics and clinical training, we can have a big impact. So the old tests, which were still used primarily for skin disease, I may say, are microscopy, culture, and pathology. And here are some examples. For example, histoplasma. The problem with this is that you need to be quite skilled to know that it's histoplasma, because it looks fairly similar to many other pathogens which are also intracellular, such as pneumocystis, leishmania, and so on. But now we have these new tests, antigen antibody LFAs, ELISAs, PCR, and more recently, Molotov for rapid identification. And what we know is that we can improve sensitivity and we can improve the time to diagnosis quite significantly. And we also have a higher level of accuracy with many of these tests. And it's also an important point that for life-threatening infections, the patient can afford a false positive result, but not a false negative result. So, if you like, oversensitivity is better than undersensitivity. So in Guatemala, we studied new patients with HIV, those who had stopped ART for more than 3 months and were looking for care, those on antiretroviral therapy also looking for care. And we screened all of them regardless of their CD4 cell count and whether that was measured or not, and we followed them up for 6 months. We looked for TB, histoplasma, and cryptococcus, and later we added pneumocystis, but that hasn't been that wasn't a focus originally because of the budget, because PCR was expensive. So Guatemala is a fairly small country, and these are the transport times between the different units that were engaged in this program. It covered about 60% of the country's HIV patients. There were 13 units involved, and the units could order the tests online so that the lab knew that they were coming. There was a courier service for the samples. They had a mobile phone alert for positive results, and then the results were posted online so that they could retrieve the results locally. So it was the IT system and the communication part was an important component of this whole program. And in 2017, there were a little more than 2,200 patients who were tested, and a significant infection of TB, cryptococcus or histoplasma was found in 5.5% of those patients, and nearly 25% died. Over time, in 2018 and then 2019, similar numbers of patients tested, but the diagnostic rate went up. This is partly because the clinical doctors were more positive about the program and were more able to get more samples and have more tests done. And so the diagnostic rate went up, but the mortality came down as well. So it went down from 24.8% to 16.5%. And then in 2020, we had a problem with COVID. So this is not complete year data, but there the mortality went up and the number of samples tested went down. And so what this indicates is that it is the diagnostic procedure, the whole program, which delivered the benefit. And there was no change in antifungal therapy during this time. So the mortality fell by 8%. Those people who did die usually died within 1 month. So that tells you how fast you have to run a program. You can't, this needs to be a rapid system. TB diagnoses fell, probably because they were misdiagnosed before, and the patients who were diagnosed, their survival increased. Histoplasmosis cases rose, so there were many more, and their survival also improved by 12%. And the mortality was also higher in those with 2 or 3 infections. So this program was screening patients for these infections, not responding to a doctor request for a particular test. The other points to make are that the procedures were commercially available procedures. They were FDA or EU approved tests. The lab was already a good functioning laboratory, and these additional tests and the program was added on top of that. It was quite cost effective in human resources and automation. Easy continuous education of healthcare workers. It also enables quality control and proficiency testing. It added general value to the country because these tests then got registered, and also new antifungals were brought in to treat the patients once the program results were known. and it increased the presence of pharma and diagnostic companies as well. And it enabled data collection for surveillance and implementation of research. So in Africa, we have been undertaking a large diagnostic survey. We were interested in the availability of 20 different medical investigations, including lab-based diagnostics such as cryptococcal antigen, spinal fluid for India ring, direct microscopy, etc. We were also interested in clinical procedures such as CT scan, bronchoscopy, corneal scraping, skin biopsy, and also we asked about CD4 cell tests. And we wanted to know which levels of the hospital system used that, whether it was in the community or in local hospitals or teaching hospitals, how often these tests were actually requested and done, and who paid for them. And on the right, you can see the countries where we have been able to collect data. So 50 out of 51 countries in Africa, we were missing data from Lesotho, and we didn't look at countries with a population of less than 1 million, such as the Seychelles or Djibouti. And in many cases, we were able to validate the data against, with conversations with the Ministry of Health, although organising those meetings was sometimes difficult. The people who inputted into this are mostly people in our Gafi ambassador network, and here are many of the people in that network. And these people, and in Madagascar, this is Prof. Lala, provide national leadership and advocacy for fungal disease. They provide a point of contact for us so that we can ask questions such as diagnostic and antifungal access. They're an educational resource. They are usually involved in epidemiological operational research, and many of our ambassadors, although not all of them, have links or have developed links to the Ministry of Health. So one of the procedures we was interested in was skin biopsy, and this map shows you where skin biopsies are or are not done. So the orange colour is where skin biopsy is essentially not done, and in blue, where it's very rarely done. We were missing a little bit of data from Mauritania, Zambia, and Zimbabwe, but otherwise you can see quite a patchy position with a lot of skin biopsies done in many countries and not very many in others. The stripes represent a private sector use of skin biopsy, and so in some countries there is no public sector skin biopsy, but there is quite a bit of private sector. And when you look at the table on the bottom right, you can see the number of countries where skin biopsies are often done, occasionally done, rarely done, or never done. And so we've got at least 10 countries in Africa which never do skin biopsies, which is a problem, and another 7 who rarely do skin biopsies. There are some. There isn't a formal guideline written by an important society specifically about skin biopsies related to fungal disease, but there are some quite helpful publications which give some indications of how samples should be processed and which type of biopsy to do. We also asked the question about direct microscopy of skin, hair, and nail samples, and you can see the map here with some countries doing this really routinely and regularly, and others not. And there's quite a lot of variability there. And again, we've got 12 countries in Africa that don't do any public sector skin microscopy examinations, and another 9 countries that do it very rarely. So this is an area that needs to be improved across the continent. With respect to fungal culture, this is a similar picture, although it varies a little bit by different countries as to which countries do and don't do skin biopsy, fungal culture. And sometimes this is only fungal culture for skin, sometimes it's only for respiratory tract, sometimes it's only spinal fluid, and so it varies a little bit. But again, we've got 11 countries that don't do any fungal culture in the public sector, and another 10 that only rarely do it. And then finally, to show you today is histopathology, which of course is used for many things, not just for skin. And what you see here is a small number of countries, in fact about 11, which don't do any histopathology at all, and 7 which rarely do it. And this is also even less frequently done in the private sector. So this is also a problem, and of course upskilling and provision of histopathology when you have none in a country is quite a big undertaking, because it takes quite a long time to train a histopathologist. A group of knowledgeable people on fungal NTDs, including Prof. Lala, contributed to a survey that Rod Hay ran, looking at the value of different types of samples for different fungal NTDs. So, for example, a swab from broken sinuses is not very useful, not thought to be useful for chromoblastomycosis, marginal for mycetoma and sporotrichosis. Impression spear slightly more useful, skin scraping more useful again, but a punch or excision biopsy or curettage really the most useful thing to do, and slightly more useful probably, according to this group of experts, from an excision biopsy. So, although I've given you information just about skin biopsy, actually there's several different approaches to trying to get good samples from patients, which vary a bit by disease. So, what do we need to do now? Where do we need to go? So, Gafi has listed a lot of diagnostic tests and antifungals on the WHO list of essential diagnostics and essential medicines. And these need to be made available in every country. We don't have a very good handle on the number of infections in different places. We have had a program of writing papers on the burden of fungal infections, and we haven't yet done this for Madagascar for various reasons. But in order to validate these burden estimates, we need the novel diagnostics to be introduced and to have clinical engagement attached to that. One of the major deficits in our area is not the research about diagnostic performance, but more how do you integrate these tests into current health systems? Which tests